Today, I'm going to be talking about the overlap between cognitive and physical frailty in persons with HIV. I have no conflicts of interest to report. Cognitive impairment and frailty are two geriatric syndromes that are common among older adults living with HIV. Cognitive disorders affect approximately 40% of individuals living with HIV globally. With the advent of antiretroviral therapy, the most severe forms of HIV-associated neurocognitive disorders like HIV-associated dementia are now rare, but mild forms of neurocognitive impairment, like mild neurocognitive disorders and asymptomatic neurocognitive impairment persist. In addition, adults with HIV exhibit frailty at younger ages than are typically seen in the general population, with a prevalence that ranges from 5 to 29%, depending on the cohort studied. Frailty is a state of increased vulnerability to adverse outcomes from stressors and is associated with declines across multiple physiologic systems. It's associated with advancing age, but not all individuals become frail as they age. If we look at these two individuals who are similar age, the woman on the left appears robust and non-frail, while the gentleman on the right appears frail and perhaps at increased risk for adverse outcomes. While we often think of frailty as a clinical state that we know when we see, there are two main operational approaches to conceptualizing frailty. The frailty as a syndrome or a physical frailty phenotype. This is classically measured with the Fried frailty phenotype, which consists of 5 measures: the slow gait, weak grip, unintentional weight loss, exhaustion, and reduction in usual activities. Individuals are considered frail if they meet at least 3 of these 5 frailty criteria. The other approach is to see frailty as an accumulation of age-related deficits that result in a state of overall poor health. This is usually measured as a frailty index. No matter which of these operational approaches you use, both classify people at increased risk of adverse outcomes and root frailty and aging. While we often think of frailty as a risk factor for adverse outcomes, increasingly there's growing evidence that it impacts expression of chronic and acquired diseases as well. In the example of Alzheimer's disease, not all individuals who have the characteristic plaques, tangles, and Lewy bodies develop overt dementia. As we can see, kind of simplified in this figure, frailty can modify this expression. So individuals who don't have any of the neuropathologic changes of Alzheimer's disease and are frail and are fit have the lowest dementia risk. But those who do have the characteristic neuropathologic changes, if they are fit, they have a lower dementia risk than if they are frail, they have a higher dementia risk. Because of these interaction between frailty and cognitive deficits, the concept of cognitive frailty has emerged as a target for prevention strategies. Cognitive frailty focuses in on this overlap between early cognitive impairment and physical frailty, and is often categorized into potentially reversible cognitive frailty, which is physical frailty plus mild cognitive impairment, or reversible cognitive frailty, which is physical frailty plus very early cognitive decline, so subjective cognitive decline without overt impairment on testing. Cognitive impairment predicts mortality and progression to dementia better than frailty alone. And because of this is a target for multimodal prevention efforts. When we look at the overlap between cognitive impairment and frailty in persons with HIV, we also see that together cognitive impairment and frailty portend worse outcomes among adults with HIV. So this is a study done in the HAILO cohort of older adults living with HIV that looked at the association between frailty, cognitive impairment, or both with adverse outcomes. The particular adverse outcomes that they looked at were falls, disability, or death. And what they found was the combination of frailty and cognitive impairment was associated with greater odds of adverse outcomes than cognitive impairment alone. In addition, in a number of cross-sectional associations, we've seen the association between frailty and cognitive impairment in persons with HIV. Um, Interestingly, some studies have also noted that pre-frailty or frailty was only associated with symptomatic cognitive impairment and not asymptomatic cognitive impairment. In addition, there seem to be specific HIV factors that modify the relationship between frailty and cognitive impairment. So this study out of the UCSD HNRP cohort found that frailty and CD4 count interacted on cognitive outcomes. So as you see in the figure on the left, for individuals with higher number of frailty syndromes, so more that meet at least 2 of the Fried-Frailty criteria, had greater expression of HIV-associated neurocognitive impairment at lower CD4 counts, where they did not see this relationship in individuals who had lower frailty scores. Conversely, when you looked at individuals who had high CD4 compared to low CD4, and those with lower CD4 below 642, so relatively lower CD4, they had an increasing proportion of HIV-associated neurocognitive disorders with increasing number of frailty syndrome symptoms. In addition, specific comorbidities seem to play a greater role in the relationship between frailty and cognition in persons with HIV, particularly depression, which is a common comorbidity among older adults living with HIV. In a study of 122 older persons with HIV, lower executive function was associated with frailty, but this relationship was no longer significant after accounting for depression and female sex at birth. Among a sample of older persons with and without HIV, people with HIV were more likely to have frailty or pre-frailty, but accounting for cognitive impairment and depression greatly attenuated this relationship. We also see these relationships between pre-frailty and cognition in longitudinal studies as well. In this study of 110 individuals in the multidimensional successful aging cohort at UCSD, they compared individuals by baseline frailty status and cognitive change over 2 years across HIV serostatus groups. Among adults with HIV, pre-frailty was associated with declines in cognitive function, as it was in persons without HIV as well. The authors in the study weren't able to look directly at frailty in persons without HIV due to the fact that there was only one person who was frail at baseline. And there were only 7 adults with HIV who were frail at baseline, and they did not see significant declines in cognitive function. But they did note that the adults who were frail had lower cognitive scores to begin with. So that might have been the reason for not being able to detect significant declines by frailty status alone. We also have looked at the longitudinal relationship between cognitive impairment and frailty in the HAILO cohort. And what we did in this study was look across the 3 years of the HAILO study at individuals who started off as having no cognitive impairment and stayed without cognitive impairment, and those who started off without cognitive impairment and developed cognitive impairment, and then assessed risk factors, including frailty, that were associated with those changes. And we also conducted similar analyses for frailty as well. And what we found was that neither frailty nor frailty at score at baseline were associated with development of cognitive impairment, but that baseline cognitive impairment was associated with development of frailty. So overall, in the few longitudinal studies that we've had, we have seen bidirectional relationships between cognitive impairment and frailty in persons with HIV. In addition, in the general population, looking at neuroimaging studies, you do see brain white matter changes associated with physical frailty. So in this community-based study of adults, uh, of older adults. 1,700 older adults underwent a neuroimaging and freed frailty assessment. And what they found was that greater white matter hyperintensity volume and poorer measures of microstructure were associated with frailty. This relationship was noted even when those with dementia and prior history of stroke were excluded. They also looked at those individuals who were non-frail at baseline and found that greater white matter hyperintensity volume was associated with greater odds of developing frailty as well. In the few studies that have looked at neuroimaging and frailty among persons with HIV, we've also seen associations between neuroimaging findings and frailty. So this study was done among 116 adults who were living with HIV over the age of 50 and virologically suppressed, and had also undergone cognitive and freed frailty assessments. And what the researchers here did was to compare structural and functional neuroimaging. And what they found was that persons with HIV who were frail had decreased cerebral blood flow to 3 regions of interest: the frontal left, which is shown in blue, the frontal right, which is shown in green, and the posterior cingulate, which is shown in red. They then examined the white matter tracts that connect these regions, shown in magenta, and found that there were significantly reduced structural integrity between the frontal regions and the posterior cingulate. So if you look at the graphs of the F1 PC and F2 PC, overall, they did not see any differences in cognition by standard testing between frail and non-frail persons with HIV. But when they looked specifically at the white matter integrity between the 3 regions of interest, they saw that that was associated with worse psychomotor speed and executive function across the entire cohort. So they were able to detect with these neuroimaging differences in cognition that were not apparent on standard neuropsychiatric testing. In addition, another study that used deep learning analysis of cerebral blood flow was able to identify cognitive impairment and frailty in persons with HIV. And so they found in this study that deep neural network models were accurate in classifying cognitive impairment and frailty compared to standard neuropsychiatric and freed frailty phenotyping. And these models also identified areas of decreased blood flow that predicted cognitive impairment and frailty, with subcortical areas predicting frailty, while subcortical and cortical regions also predicted cognitive impairment with shared subcortical areas in the amygdala, caudate, and hippocampus. And while these epidemiologic studies and neuroimaging studies have given us greater insight to the relationship between cognition and frailty in persons with HIV, the main challenge that we see as clinicians is directly addressing cognitive impairment and frailty for persons living with HIV. And one strategy might be to target specific risk factors that independently contribute to cognitive impairment or frailty. But cognitive impairment and frailty also share a number of risk factors. So either targeting these shared risk factors individually or multi-component interventions that target multiple shared risk factors like sedentary lifestyle, nutrition, and mental health could have additional benefit in this population. In addition, prioritizing these individuals for comprehensive geriatric assessment to modify these multiple risk factors could also have additional benefit for older adults living with HIV to preserve cognitive and physical functional health. So in summary, cognitive impairment and frailty are common geriatric syndromes among older adults living with HIV. In the general aging population, frailty influences expression of cognitive impairment. In adults living with HIV, we've seen cross-sectional associations between cognitive impairment and frailty. and limited longitudinal analyses have also shown possible bidirectional associations between frailty and cognition. Structural neuroimaging and machine learning models can distinguish and identify brain regions involved in these overlapping syndromes. And interventions targeting shared drivers of cognitive impairment and frailty may have the greatest potential to improve health outcomes in older adults living with HIV. And with that, I'd like to acknowledge my funding and mentors and collaborators, and thank you for your attention. Thank you.